We record the sessions for educational and quality improvement purposes, and we will share all materials after our session. You can view previously recorded sessions by visiting the CTSI YouTube playlist, and I will put the link in the chat. Today's session is brought to us by Dr. Dennis Scanlon. Dr. Scanlon's presentation is titled, Assessing the Degree to Which Evidence-Based Informs the Use of Opioid Settlement Funding. Is translation happening at the community level? Dr. Scanlon is the director of the Center for Healthcare and Policy Research and Distinguished Professor of Health Policy and Administration at Penn State University. His research focuses on understanding the role of measurement, incentives, quality improvement, and individual and organizational behavior change for improving important healthcare outcomes, including clinical quality, patient experience, and economic efficiency. Dr. Scanlon has important expertise in the area of healthcare payment and financing and interventions to improve the value of healthcare services provided to patients and patient populations. He has been principal investigator on many funded research projects and has a focus on bridging the gap between clinical and community-based care to improve the quality, value, and cost effectiveness of chronic illness care. Dr. Scanlon has published more than 100 articles, book chapters, and reports, and is a frequent speaker to academic, policy, and practice audiences. He completed a bachelor's degree at Villanova University, earned a master's degree in economics from the University of Pittsburgh, and completed a doctorate in health services organization and policy at the University of Michigan. And with that, I will turn it over to our presenter, Dr. Dennis Scanlon.
Great. Thank you, Jessica. And you can hear me, check, and see the screen, the slides, right? Great. Well, thanks for the invite and happy to share some of the work that really is team-based science. And I'll talk right now. This is a collaboration of Penn State researchers and a number of folks at Penn State, and then also some colleagues at both Pitt and Temple University as well. And, I call this community engaged translation science to support opioid remediation because I want to touch on the community-based nature of this. And I'm a member of the Community Engaged Research Core for CERC. And so I want to talk about some of the interactions with, community, and we'll talk about what community is. And then also talk about, translational science. And I actually want to hit on a couple of different aspects of that. So with that, this is the outline for today. And we'll start with some of those definitions and really why I think they're important, but also how I think they are used very similarly, but perhaps somewhat differently among scholars, depending on kind of their discipline and their background and training. But I think mostly similar. Sometimes we use terms in different ways, but we mean the same thing. I will give a brief background because it forms the context for the study of the national opioid settlement and then what I'll call Pennsylvania's implementation, because this is played out and is playing out differently in many states across the country, although certainly some similarities. I view the work that we've done here as going back to about 2016, 2017. That's really when this all started for me and for the first Penn State team that was formed. So it's hard to believe that was 8 years ago today, or 8 years ago. And I'll talk about this work in 3 different phases, including, importantly, the current phase that we're in, which a number of folks are involved with. And so we'll get to engagement with communities. We'll get translation to multiple constituents within the Commonwealth and thinking about topics such as using an evidence base. So I think many on the call are probably familiar with these terms. And what I will say is, so my background is in public health and economics. I do a lot of health policy related work. I'm not a clinician, but I work very closely on almost all projects that I work with clinicians and clinical teams, depending on sort of the nature of the project. So I've done work in diabetes and certainly work with practicing clinicians, with endocrinologists, other scholars and researchers that know quite a bit about the disease, its prevention, and such. The same thing would apply here when we're talking about substance use, when we're talking about opioids, when we're talking about the treatments and the challenges and prevention that come with it. I'm not a particular expert in this area, but I work with a lot of people who understand prevention, who understand treatment. And so, one might ask kind of what is, my own comparative advantage as part of a team. I've done a lot of community-based work where, again, community can be defined at a variety of different geographic levels with various participants. I've looked at interventions that are rolled out and decided on at that community level, again, depending on sort of what community means. But ultimately, in many of these types of approaches, the end goal is to improve the quality of care, the quality of life for individuals. And those individuals are sometimes patients. They're called other things, community members, consumers, in a variety of work, there's a lot of different terms used. But generally speaking, the goal is to take an intervention. And oftentimes some of these interventions are rolled up interventions that are very specific public health or clinical practice interventions and target them to scale for larger populations. So I mention that because these terms have certain meaning to me in the work that I do. And I know many are familiar with the traditional T1, T2, T3, T4, and I think that's a very useful model. But oftentimes when I think about translation, when I think about implementation, when I think about applying an evidence base or dissemination, it really applies to the specific context that I'm working on, and in this case of opioid remediation relative to the settlement at a national level and how that translate to Pennsylvania specifically. These terms and these definitions have certain meaning. So I want to sort of throughout try to emphasize and highlight where there's been partnership with community, and again, at what level of geography and what participants have been involved in that may be similar, that may be certainly similar and different to other work that I've done. And for many of you, it may be similar or different to where your focus is. And then the same thing with thinking about evidence base and putting that into practice and so forth. So I won't read these definitions here because you've now had time to take a look at them. But I assume that we're all generally familiar, but we apply these things in the context of our own work in different ways. So really the contextual background for what I'm going to talk about today, I need to sort of talk about three phases of this work to support settlement and now remediation coming from the settlement dollars. So we started in 2017 with what I call the pre-settlement work. And this was, I think we're all at some level, some more than others, generally familiar with the opioid epidemic, with the crisis, with the harm that has resulted. And what I'll get to in phase 3 is what's happening with the dollars, the billions of dollars that have been negotiated for settlement nationally, and the probably close to $2 billion that are coming into the Commonwealth of Pennsylvania, largely coming from industry. And by industry, what I mean here are manufacturers of prescription opioids, distributors of those, including kind of wholesale distributors, but also retail pharmacies. It's primarily the industry that has agreed to provide through settlement the funds that now come into the Commonwealth and are to be used for what has been termed opioid remediation. But prior to getting to that point, there was a lot of work that needed to be done. And I think this work very much was community partnership-based work as well, again, with community defined in different ways. So the original pre-settlement focus was around understanding the monetized loss to society due to opioid mortality and morbidity, and really what state government as well as local governments faced in terms of having to address the crisis. And so this work was an engagement with Pennsylvania's Attorney General's office, but also with county and state officials. So when I think about the broadest sense of community there, which is different from where many other CERC-related or community-based projects focus. Here it was, thinking about the Commonwealth, thinking about its various political jurisdictions, and ultimately the harm that was done and the goal to kind of recover monetary compensation for that harm. The second phase was, once those funds were secured, how did they get allocated within the Commonwealth? Because in the federal scheme, the way those funds were secured, it gave lots of latitude to each state to determine how those funds would be used. But in the context of Pennsylvania, there was a lot of work with counties and local municipalities to arrive at agreement into initially how $1.6 billion in settlement funds in Pennsylvania would be allocated, but also future settlement funds as well that will approximate close to $2 billion over about a 18-year period when all is said and done. So I'll talk a little bit about that, and then measuring where we're at now, which is trying to capture how the funds are being spent and to measure the population health impact. And that involves a number of different steps. So briefly, I'll really just put this up here and move on, because I think that many are familiar with the opioid crisis, the harm, the damage, the lives lost, the tragedy, the impact on families and communities that has resulted from, sort of this horrific epidemic. And one of the pieces in that first phase of work that we did was really to try to understand and also, to be perfectly honest, around, settlements always start with litigation and the threat of lawsuits. And if there's settlement, it's when, sort of the litigating parties come to an agreement to say, we're not going to take this all the way through the legal process, but we're going to agree to settle. And but that doesn't happen if those who are claiming harm and damages don't have good evidence, don't have data available. And so at the very beginning of this journey, we worked with attorney general's offices, I think 44 of them from across the United States, starting with a connection in Pennsylvania, to really sort of understand what the impact was to states, to populations, to specific programming, and how that was monetized, in particular due to services and programming that states provided or had to provide to address this epidemic. So very proud of the collaborative work that Penn State researchers did to on this project, and this was a collection of research papers that we put together in that early work. We, I think, somewhat cleverly titled this volume "Deaths, Dollars, Diverted Resources: Examining the Heavy Price of the Opioid Epidemic," because we were really looking at multiple things. And you see that we had a number of commentaries here, but the research that was done looked at, the impact of, for example, on the Medicaid program. Doug Leslie and others led that work, and using Medicaid claims, looked at sort of what was the cost of having to address the crisis from a medical perspective and a pharmacy perspective. We had those that looked at the impact of our criminal justice system, whether it was policing, whether it was the judicial system, kind of, or otherwise. What were the costs and what were the implications to the criminal justice system? We looked at the child welfare system, including foster care. We looked at special education, neonatal abstinence, for example, and Paul Morgan and colleagues led that work. And then we even looked at things like the impact on tax revenues for those who became eligible for means-tested programs, those who were no longer able to work, and so forth and so on. And so this work formed the basis for kind of understanding what the damages were, and therefore led to, some monetary, with a lot of things, led to some evidence that helped to support the settlement and the financials that came from that. The next step, once the national attorney generals negotiated that settlement, was to say, okay, Pennsylvania is getting this big influx of dollars, but how should those dollars be allocated towards programming to address the crisis? And as part of the settlement, there were some guardrails put on that. A lot of the lessons were learned from tobacco, where, quite frankly, tobacco settlement dollars had few guardrails. And in some cases, states used monies for roads, bridges, potholes. And in some of the reported most egregious cases, used money to subsidize lost income from tobacco farmers who would see their sales fall as a result of more evidence around the negative health impacts of tobacco use, for example. So there was a lot of concern about putting some guardrails and parameters around the use of the opioid settlement funds being for substance use and opioid abatement purposes, and not for these other things like to balance state budgets or roads and bridges. And I think most people feel that that's positive. But it was a little bit wonky as well. The broad term was opioid abatement. And so a lot of dialogue around what's the definition of abatement? Does abatement include compensation for past damages, or is this more of a forward-looking function? And the answer to that is yes. And then there was a whole list, which is affectionately called Exhibit E, of the types of things that these dollars could be used for. And there's a lot of specificity. It does cover a lot of public health, treatment, education, research-related purposes in this broad area. And so that's the good news. But then the question becomes, who makes the decisions for how the money is spent? And interestingly enough, in learning from tobacco, in Pennsylvania, it was very much a political socioeconomic exercise. But ultimately, the point was decided that 70% of this, multi-billion dollars in the Commonwealth of Pennsylvania spending will be determined by counties. So we have 67 counties in the Commonwealth, and 70% of the funding will go to counties by formula. I'll talk about that formula in a moment, where the counties will make the specific decisions about how to spend the money, ultimately, of course, on health-related purposes to address this crisis. And I mentioned this, we published this article on the right in the Milbank Quarterly out of some work where we were engaged, again, post-settlement, to get to that point of what would be a fair allocation financially to the 67 counties in terms of who should get what. And this is just an example of a table that we put in one of the paper. But I will say that a lot of this work was very much interactive with county level constituents, with state government level constituents, with representatives from individual municipalities, and with individuals that represented various patient or community groups, as well as advocacy groups within the Commonwealth. So it was a very interesting process to be involved in, like I say, a political socioeconomic perspective. As a team of researchers, we tried to bring data to bear and to be as objective as possible, because quite frankly, the task here was to decide how fairly to allocate more than $1 billion. And there were people lobbying so that their county, their community could get more versus less. And so we arrived at a formula that ultimately all agreed on. And as part of that process, we entertained alternatives that might be mentioned by community stakeholders or others participating in this process. And we tried to sort of estimate what the impact of that suggestion would be, and then be a part of the broader conversation in terms of arriving at the decision. So that's a very, very little description of a very complicated process, because I want to get into kind of where we're at currently, but I think it's important background. So further background on this before I get into kind of some of the details that we'll talk about translation, that we'll talk about evidence base and so forth and so on, is as a result of all this nationally, when you have many, many billions of dollars being sort of provided through settlement and then channeled into states and channeled into communities, you certainly have a lot of watchdogs and a lot of individuals that are interested in understanding how that money's being spent. Is it being spent positively? Is it going to make a positive health impact on communities, on individuals, on families and stakeholders? And there's a lot of scrutiny. So, early on, this is a couple years old, but, an entity claiming, this is the opioid settlement tracker, that very few states have promised to be transparent about how their expenditures would be used. I think these numbers need to be reflected and updated. This is a little bit of an old slide. Nationally, the narrative was not only, okay, well, settlement fund spending is not transparent, but it's moving very slowly. Millions in opioid settlement funds sit untouched as we have this public health crisis right before our very eyes. And so, what are we going to do as part of that? And then also concerns about is the money being wasted? And interestingly enough, per this NPR story, and I'm going to take just a brief pause because I think this is relevant. There is a concern that money will be wasted, and that's always the concern with public government spending more generally. But then certainly when one, and this is where I think the NIH terms of evidence-based, evidence-informed, and translation and dissemination come into place is how do we sort of help to make sure that what the money is being spent on has a basis in evidence, or is at least informed by evidence? And I know evidence informed and evidence-based are common terms that are used pending sort of the nature of the scientific evidence. So I just want to pause here, and I'm going to share my screen again. And I want to play a brief clip for you here because I think this is important. So let me share my screen, and I think I'm not going to play the whole thing. You have the URL, but this kind of gives the flavor of part of our work.
This is Marketplace. I'm Kimberly Adams. The opioid epidemic has led to hundreds of thousands of overdose deaths. Now, state and local governments are beginning to receive the first parts of $50 billion in settlement money. And those in charge of distributing that money are getting the hard sell on what to do with it. Aneri Patani is a senior correspondent with KFF Health News and wrote about this. Welcome to the program.
Thanks for having me.
Let's say that I'm a state official involved in distributing some of this money. What does my email inbox look like these days?
It is full of people asking you to have a brief call, to meet for a short time. They can tell you about their new product then and how it relates to the opioid crisis and how it's going to prevent addiction or save lives or help them turn around the tide of this epidemic. There is just so much marketing going at these state and local officials who are in charge of the money right now.
And not just an email. I saw in your piece that they're putting advertisements in, like newsletters and magazines targeted at state and county officials.
Yeah, they're going wherever their audience is. So they're trying to do whatever they can to kind of get on folks' radar and say, here's an opportunity. You have this money coming. You could spend it on our product.
Give me a couple of examples of the sort of products that jumped out to you that were being advertised in this way.
So one that really caught my attention is a product called Ebola Wrap. It is a device for law enforcement officers. You press a button and it shoots out this Kevlar tether that can sort of fly through the air and wrap around someone's body as a way to detain them. And they have sent out, we've obtained through public records requests and other means, emails to different police departments with sort of like a 2-page Q&A document about how the opioid settlement funds can be used to buy this product. A lot of...
Okay, so I'm going to stop sharing here. Go back to Zoom. And I think I have to switch my screen. So, okay, I'm going to share again. Jessica, I'm back. Am I back to my slides? Okay, perfect. And you heard that audio, correct? Okay, great. So, the notion here is that there's $50 billion circulating across the United States and several billion in Pennsylvania, and there's a lot of interest in getting a part of that money. In fact, if you go on and listen to the rest of that story, somebody says it was industry that caused the problem, an industry that's provided the dollars through settlement. Now it's new forms of industry seeking to get the money back, right? And so the question becomes, what is the best and most effective way of using the funds? And is there an evidence base to inform that? An evidence base that would be reflective of good population and public health approaches to making a difference, to treatment or prevention that would, sort of address the needs of individuals or of groups of individuals within communities and within, specific pockets of communities and so forth and so on. And so that's really kind of where we are now in our work. What we're doing in this third phase, and I want to talk a little bit about this and then get to, the point of how an evidence base might inform and how we might understand whether an evidence base is being used, is to really say that our work now has shifted to collecting the information on how the funds are being used, but very specifically what the funds are being used for. What are the interventions that the funds are paying for? Who are they targeted towards? Is there an evidence base for them? And then ultimately, what is the population health impact of the interventions that are funded through the settlement? So this is where our partnership with colleagues at Pitt and Temple, along with a Penn State team, have developed a reporting tool. We're collecting this information. And then there's a couple other aspects of that. I mentioned on one of those earlier slides criticism that there wasn't transparency about how the funds are being used. In Pennsylvania, there's a desire and an objective to be transparent. And so we're in the process of finalizing a public-facing website that will do so. The one thing I should mention about this before I go to this next slide is that as part of the legal process in the Commonwealth of Pennsylvania, the administrator of these funds is something called the Pennsylvania Opioid and Addiction Trust. And it was formed by the Commonwealth Court of Pennsylvania. It has 13 trustees, and the way they're appointed was specified in the trust. And again, counties and municipalities agreed to be governed this way. So it is the trust that has contracted with us to do this work. We have and are seeking additional forms of funding to support our research. But the data collection that we've designed and the transparency that we're reporting, and ultimately some of the early research is being supported through our collaboration and work with this with this trust. And so that lets us get close to the ground and continue to work with communities and counties and various stakeholders. So from a research perspective, and I know most of us are researchers on the call here, there are a number of different things that this database that we're creating and collecting can do. First of all, it can inform the trust for its fiduciary responsibility, which makes sure that the monies aren't spent on potholes or bridges or roads, but that they're spent relative to what's called Exhibit E. It should be Exhibit E rather than Schedule E, and not towards other things. Beyond that, it's, okay, can we characterize how the funds are being spent? And what does that tell us? How much in prevention? How much in treatment? What types of populations are being impacted? What's the variation across the Commonwealth? And then, of course, we move to sort of ultimately the most important questions that people want to focus on is, does it make a difference? So great that we've got $50 billion, and $50 billion is probably not nearly enough to address the havoc of this epidemic. And in Pennsylvania, maybe close to $2 billion. But $2 billion can do some good things if that money is spent wisely. And so that really is the key critical question over time is, what has been the impact from a public health perspective, from a population health perspective, and for the health of individuals in particular communities? And then can we learn anything about, what some might call the comparative effectiveness of different approaches? So lots of different research questions. This is just a blinded screenshot of some of the data that we collect. We have an online data reporting tool. We do this twice per year because there's a lot of money, and I'll show you some examples of that money here in a moment. Just if we look at the remediation program name here, connecting with cookies and coffee, something on the order of less than $9,000. Or if we look at FDA-approved medications for outpatient treatment to treat opioid use disorder, this was an expenditure of $150,000. It runs the gamut. We see quite a bit of variation, and all of this falls legitimately within Exhibit E, which means that these are legitimate expenses related to opioid abatement. But when I say legitimate doesn't always mean evidence-informed or evidence-based, right? It means that the subject and the details of the intervention are related to opioid abatement. But there was no specific requirement that there had to be proof of evidence-informed or evidence-based. And so that's one thing that we're looking at. And we actually look at this as a very interesting and unique set of circumstances and context, which allows one to study, is there a connection between what does exist in science and in literature as an evidence base on this topic? And then when there are real world choices being made by communities, by counties, by stakeholders through the various processes that they use, are their decisions going to that evidence base, either in part or in full or not at all? And so that's a big focus of what we're working on. Just to give a magnitude of the money, you know, part of this is an accounting exercise as well. So this is as of, I think, last spring, but actually I think in terms of how much has been distributed so far, still pretty relevant. You know, there's been about $170 million that have been distributed through December 2023. There will be another major distribution, probably on the order of, I think it'll be more than 70 million coming in December of 2024. But so far, or at least as of last spring, only about 70 million that has both been spent and committed. And committed means there are plans to spend it. It's just not money out the door. Another way of looking at it was this, and again, this was as of May 2nd, 2024. But this addresses that other slide that I mentioned where, you know, there's some indication that concern that the money's available and it can be helping people now, but it's sitting in bank accounts within counties and not being used. And that gets into another very interesting question, which is, even if there is an evidence base, can you legitimately and effectively, through implementation, through translation, through program development, would it be wise to get all the money out the door and on the ground working today? Or are some of those key things that we study in science, like fidelity of intervention, implementation, are they things that would suggest, nope, slow it down, because in order to take even an evidence-based intervention and put it into practice locally, if your intention is to do that with fidelity, it takes time. So this is a big tension in the Commonwealth between the money's available, it's not going out the door. You certainly want it to go out the door and be effective. And part of effectiveness is hopefully being informed by an evidence base. But part of effectiveness is also making sure that you don't rush too much so you can focus on things like fidelity of implementation. And these are all terms that those of you who have some familiarity in translation, evidence-based implementation research and such, dissemination research are probably well aware of. So other things that we're doing, and this is really where we're right smack in the middle of this right now. Let me try to explain this. On the right-hand side, Exhibit E. Exhibit E is the document that's part of the national settlement that says these are the categories that one meaning a state, a municipality, a county, can spend money on. So it doesn't include roads and bridges and potholes, but it does include a lot of treatment, prevention, education, professional training services, recovery support. You know, it's pretty comprehensive. The problem is, well, part of the challenge is the data that we get in a reporting tool requires those who are receiving the money to report by checking off boxes relative to this Exhibit E. But it turns out that Exhibit E is, I'll use the term somewhat wonky. It muddles together various types of services and populations and categories of intervention in a way that is most definitely not well understood by a lay population or even a population of policymakers. But it even challenges the understanding of well-trained clinicians or well-trained individuals that do focus on and understand the evidence base in these categories. But because of the nature of the settlement, Exhibit E is really what is required from a reporting perspective. So as we think about our research, which again is designed to characterize and explain to all kinds of constituents how this money is being put forth and used, but also as we try to connect that use to important outcomes on populations, we've basically said we need a way of creating a taxonomy that is more intuitive, that is more reflective in probably a better characterization of the uses of these funds and not simply rely on Exhibit E. And so we've spent a lot of time looking at and developing a taxonomy to try to do that, to take a very broad-based and large laundry list, if you will, in Exhibit E, and to whittle that down into more meaningful, more parsimonious categories of interventions, and subcategories that would be better aligned with linking to outcome measures over time, but also better aligned to communicating to a variety of constituents how this money is being used and hopefully which populations will benefit from the use of this. And so in developing this taxonomy, of course, we start with our own knowledge base, but our own knowledge base has been informed by the work of many others nationally, such as the CDC, such as SAMHSA, such as NIDA, and others. And so that's really where we started. And so, for example, right now we're in a category, we're in a phase where, we've developed these categories on the left. But part of the community engagement piece of this is not just to take, even though we ground that in these national organizations that have funded many people and have done good work, that doesn't necessarily mean that this has resonance and relevance with people on the ground. So, for example, within the past couple of weeks, we took this categorization in our methods and our approaches to the Pennsylvania Association of County Drug and Alcohol Administrators at their meeting, and we ran it by them. And the feedback that we got is, okay, but there are things in this that we don't like. Supply reduction does not resonate with us. We don't think that makes sense. We don't think that is meaningful to people in communities. There was a comment related to children, youth, and family services saying, could you call that services for children, youth, and families? Because the way you have it now makes it sound like the division of county government that is named and called Children, Youth, and Family Services. So this is a matter of getting feedback from communities, community members, and others. And where we're going next based on that meeting is that PACTA and its members are going to provide for us a committee that will work directly with us to try to make sure that we get to categorization, terminology, nomenclature that makes more sense at the community-based level. So we're going to get feedback from those on the ground that are directly doing the work. And oh, by the way, one of the comments that came from this as well is how best to incorporate family members that have lost loved ones as a result of the opioid crisis or overdose, other community-based stakeholders that represent treatment and prevention services and so forth and so on. So I think that's part of the community engaged piece of this work. We also want to focus on which populations are being served, right? And so prevention sometimes is very targeted towards youth or towards even specific types of adolescent or youth or school-based programming. In other cases, it's more broad-based. And so this is important for a whole variety of reasons, both for communicating publicly how the funds are being spent in a way that's meaningful, but also for purposes of the research, which is to look at and make assessments of if an evidence base is being consulted, but then also what is the impact on outcomes over time. So I think in the interest of having just a couple minutes left before we get to maybe opening this up for questions and answers, we've also started to look at this question of, as we look line by line about settlement fund use, one of the other goals is to say, what is the evidence base, or is there an evidence base for how these are used? I'm going to skip over a couple slides and talk a little bit more about this work here. So again, a couple more definitions that we found, if we look at from HHS, evidence-based treatments for substance use disorder can reduce substance use, related health harms, and overdose deaths. High-quality treatment can also increase social functioning. The strategy, therefore, focuses on reducing barriers to accessing the most effective treatments, using motivational and cultural enhancements to encourage those who might be reluctant, advancing strategies to improve engagement and retention, and continuing to develop new therapeutic approaches. So, again, one might quibble and or want to either narrow or extend that definition a little bit, but I think it's a very reasonable working definition. And so one of the things that we're doing now, in addition to that taxonomy that I just mentioned, is trying to consult what information is available in the public domain about what would constitute an evidence-based intervention within the broad area of opioid remediation which is the area that is covered by these funds and how these funds can be used. And so we've gone out and have looked at a variety of sources nationally that have spent some time detailing and providing a compendium of what is considered evidence-based in the field. So for example, the CDC has something they put together called evidence-based strategies for preventing opioid overdose, what's working in the United States. And here are some examples of what falls into that. The Bloomberg School of Public Health at Hopkins has something called Principles for the Use of Funds from Opioid Litigation. So very targeted and focused towards the understanding of not only the litigation, but the settlement in remediation. And so some of these things, for example, sort of play out in documents that look like this. This is from the Legal Action Center, Evidence-Based Strategies for Abatement of Harms, authors from Harvard, Hopkins, Yale, Michigan, Stanford, Penn, and others, really looking at specific components, a summary of what the evidence says, supporting evidence, and then, as often exists in evidence-based or evidence-informed, it's not always a binary variable, but maybe more of a categorical variable. Is the intervention well supported in evidence? Is it supported? Is it less well supported? So it's more of a categorical assessment rather than an either or a binary indicator. The CDC has done similar work, in really talking about anything from, promoting education and awareness of 911 Good Samaritan laws, for example, to help those that are in overdose and need care and help immediately, to targeted distribution of naloxone, medication-assisted therapy, screening and toxicology testing, academic detailing, educating providers on appropriate prescription of opioid use or of opioids, et cetera, et cetera. So we've gone to a variety of these sources and said, there's evidence from these sources that there are evidence-based interventions. And so our goal then, and SAMHSA has examples as well, what we then are endeavoring to do is to take the list of data that we're collecting of how the funds are actually being spent and to sort of cross-reference those against this evidence base and say, to compute some indicators such as which proportion of interventions actually are grounded in an evidence base or informed by evidence. Which proportion of all the dollars being spent fall into those categories. It may be the case that some of the spending can be for very important and valuable infrastructure building, community connections or conversations or other types of programming that may not be grounded strictly in evidence, but might be very important for addressing the crisis within the community, right? So we have to wrestle with that as well, is that 100% of interventions or 100% of all spending, it may be wrong to expect that would be all grounded in evidence per se. But certainly, I think many people would say it should be very reasonable to believe that much of the spending should conform. And so it really becomes an empirical question that we're in the early stages of. And if there's anybody on the webinar today that might have an interest in doing this kind of work and really getting into the weeds to help us evaluate, kind of using good research techniques, inter-rater reliability and assessment and so forth and so on, we certainly could use some more support and help from our team. So that's kind of the gist of it. I think I will, in the interest of time, just maybe take 2 more minutes to say, we have, again, in very initial look, and this is through a student that has been kind of working with us, we've made some judgments by picking a couple example counties. And we've looked at, yes, what types of interventions appear to be grounded in an evidence base based on what's reported to us from these counties, things that we believe are no. And then, of course, a lot of other things that are unclear, which gets us from a research perspective into a mixed methods study design, where, yes, we have observational data that we're collecting that can be coded and quantified, but we likely will need to supplement our understanding of those interventions by doing some more in-depth, detailed qualitative work through key informant interviews, through other document review and things that will give us more information to make judgment, particularly around those things for which they're unclear based on the data that we're collecting. The last thing that I will say is, part of what we're working on here too is public reporting, and to create for the public, going back to one of those early slides, an awareness of transparency. These funds are for the citizens of the Commonwealth of Pennsylvania, because it is the citizens in the communities in the Commonwealth of Pennsylvania that presumably has been harmed by this epidemic, by the behaviors of industry. And so the funds are meant to improve the health, to abate the problem going forward, and to make Pennsylvania a healthier place to live, and the same within our communities. And so there's an expectation that there's awareness and transparency around how these funds are being spent. I'm going to skip the details other than to say that we are very much in the stage of building an interactive website. Let me just kind of give you some examples. We've purchased the domain name paopioidsettlementdata.org, and there will be links to it from the trust website if you were to click, for example, on what ultimately might be up there that says public transparency. And of course, one could go directly by typing that name into a URL, or hopefully others will link to this as well. In an initial draft, I and others said, let's get rid of Harrisburg and let's get rid of the state capital. Let's use a picture like this, so we get kind of the government connotation out of this a little bit. But the idea is, what we're really focused on is the reported categories would be the taxonomy that I talked about, how we explain to a myriad of constituents. The constituents for this website are citizens of the Commonwealth, those involved in the trenches and treatment, prevention, people in counties, in communities doing the hard work to serve those in need, state policymakers, local policymakers, elected officials, anybody else interested, right? And so as we go through that more parsimonious taxonomy, this tab would provide a little bit more details. This tab would allow one to drill down to a county-specific level and see how the funds are being used. And this tab would be more of a aggregation across counties of how those funds were being used. So I don't know why I have all these other slides. This is a working example of a dashboard we have where one will be able to pick a county and actually get line item detail about what programs are being funded, how much money was spent, and if you were to click on the URL, the hyperlink for these programs, to be able to even see more line item detail about how those funds are being used. So I guess let me wrap up here by saying, from my perspective, there's a lot of, when we think of CTSI and we think of its various components, I would argue that there's a lot of relationships we've had with community members at different levels, whether it's the Association of County Level Drug and Alcohol Administrators, people in the trenches, we are working with and getting feedback directly. We're working with county executives, county commissioners. We're working with entities that represent a variety of these stakeholders, such as the Pennsylvania County Commissioners Association. We're working with various stakeholder groups and advocacy organizations and others. We're working with the Attorney General's office. We're working with the trustees on the trust that was established by this settlement. And so in that way, I very much view this as a form of community engaged research. Certainly, I talked about the evidence base, and we're trying to understand the degree to which the evidence base is being used, and also, if not, why, right? It's one thing to say the NIH has funded all this research, we have an evidence base and it should be used, but we think this is a really good example to see whether the evidence base does get used. And if it doesn't, the key important question is why. When the NIH invests all kinds of millions, hundreds of millions, if not billions of dollars, and we have it, and this is a great example where it can be used. If it's not, or it's not in some cases, can we explain that? And is there a way to sort of improve that going forward? And then, dissemination, translation, these other types of things come into play here as well. So with that, let me stop in a few links to some resources here, but I'm certainly happy to answer any questions. And I think I'll stop sharing my screen so I can turn it over to Jessica, to you, if you want to navigate the Q&A.
Okay, yeah, sure. So if anyone does have any questions for Dr. Scanlon, feel free to unmute yourself and you can ask the question or you can type it in the chat. I want to thank you, Dr. Scanlon, for a fantastic presentation. It was very informative. It should generate a lot of questions.
Yeah, and I'm trying to monitor the chat, but if you see anything that I'm missing,
Okay.
let me know. You know, maybe as we're waiting, again, I'll sort of reiterate, if there's anyone that is interested in this topic or aspects of this topic, because I think there are a variety of different aspects, right? I really personally think this is I don't know of too many other examples where, you know, we talked about, you know, the use of evidence in practice, you know, for example. So you know, another project that I've worked on is diabetes prevention, in the diabetes prevention program, and in the evidence that came out of trials and others on how best to prevent the onset of type 2 diabetes, you know, through a variety, you know, through the DPP, which includes education, which includes behavior change and motivational interviewing and so forth and so on. A lot of the focus of that work is to work with provider organizations, healthcare delivery organizations, or entities, community-based entities like the YMCA, to think about how we can get that evidence from a program that's been studied and put it into practice. You know, we certainly think about best practice clinical interventions in how we educate providers of various types to change their practice patterns. You know, this is really at the community level intervention point. And, you know, I don't know, I'm sure there are probably other examples, but the fact that there's $50 billion available to make choices about intervention implementation, I think is just a really great example, and maybe a one-time kind of only example, to just assess whether the evidence base that we've amassed, sometimes developed very specifically for clinicians, sometimes developed for communities, but is it consulted when decisions are made about this spending? And so if there are folks that are interested in that kind of work, feel free to shoot me a message, because we can use others who are interested in rolling up their sleeves in being a part of it.
And it looks like we have a question. Someone raised their hand. Sean McCormick, you want to unmute and you can ask your question.
Yeah, hi, good afternoon. Thanks so much for that presentation, Dr. Scanlon. Really a lot of important considerations and key research questions there. Thank you for all the hard work that you and everyone on your side is doing. I'll send you an email, but I'm one of those folks that's willing to roll up my sleeves and dig in on some of this research. I'm the Associate Director of Public Health Programs at Latino Connection, and we're an organization that sort of sits in between communities, healthcare, government agencies, and businesses. And we do a lot of partnerships and collaboration and that result in things like prevention, health promotion, and community-based and clinical services. So we found ourselves applying for some of these funds and creating programs that we think fit within the needs. And then the question becomes, you know, how are we going to evaluate this thing? So I guess I have a couple questions for you, or a couple thoughts. One is, I would love to hear more, if you could say anything more about what the research or the question related to, you know, should all the money be spent at once, or is it better to slowly roll this out and build capacity along the way? And if there's any sort of crystallization of those research methods around that question, I would be interested to hear about that. And then sort of a thought that I have is, I'm wondering if it would be useful for the counties and for Pennsylvania and other states to have some sort of like committee or opioid program evaluation advisory, opioid program evaluation advisory committees or resources, where a county might say, okay, we've got this like community conversations program that's being proposed by 2 organizations that we trust and know do a good job, but what they're proposing is not something that's evidence-based or even very evidence-informed, but it's going to have probably a high impact because they've got the right relationships and they're just good at these sorts of conversations. And then the county and the groups that are proposing or delivering that sort of conversational program would be able to access the evaluation committee or resource and say, okay, here's what our program looks like. Can you help us design an evaluation that's appropriate for this type of program? Yeah, so just a question and a thought. Thanks.
Yeah, no, lots of great questions, Sean. Thank you. And really you hit on some of the really key things that we've started to think about, and I think we need to continue to think about. So I took a few notes. Let me just maybe hit on things. I love the idea of a evaluation advisory committee, and I think it's something we probably should start to formally think about very soon, because so much of our focus has been collecting the data and thinking about public transparency and categorization. And, I think we've been able to sort of put that on the wayside for a little bit. But I think, there's a whole lot of reasons to have an advisory committee. One is that we've got lots of experts who understand evaluation, but also to make sure that the product of the evaluation is fair, it's useful, it's going to inform, sort of the constituencies that need to be formed. So I love that idea, and I've certainly made that note. I think, the question about should all the money be spent right away? Should it be staggered? I don't know that there's an answer to that, but I've got a couple thoughts. One is, I think the beauty of having 67 counties make decisions is that we'll naturally see some variation. And I guess if I was forced to sort of provide thoughts on this, what I would say is, in all this work, and I would assume you in particular with the work that you do would agree, community context really matters, right? And while we have 67 counties, they're all contextually in very different situations, both in terms of the magnitude in the way in which this crisis is playing out, but also what interventions they currently fund and programming they currently have in place. And as a result, sort of how best they can take these resources and use them effectively. And so that gets me to thinking that I don't know that a one-size-fits-all directive makes sense. But this is also a point of tension with the trust, in that they do want the money to be on the street, so to speak, and working. But I don't know that it's a one-size approach. The last thing I guess I would say is some of the comments you made around evaluation. I could talk for the next 5 hours about this and love to do so. There are so many methodological choices that are important here. The interventions that are happening within a county or across the Commonwealth are really cocktails of interventions, right? There may be some $10,000 interventions that happen. There may be $500,000 interventions. It's a cocktail of things. And the question is, are we trying to sort of associate each individual intervention with an outcome? If you're funding a program and running a program, you might want to make the program implementer at least think about that. But if we think about population health level outcomes, we may need to think about these as composites or aggregates. And then the question is, you get into issues of weighting and timing. When you think about outcomes, we need to think about sort of what is the likely lag that one might expect before the outcome that you're measuring is going to be impacted by the intervention. What's the power that you need from a quantitative analysis perspective, right? So that's just scratching the surface on a whole myriad of important evaluation questions. So that's where I think the advisory committee could be useful as well. And maybe the last thing I would say in response is what I didn't mention, and I'm glad at least your comments prompted me, there's an opportunity for this information to be used as a learning community across counties to learn from each other. So part of the transparency piece is for example, the work that you do and the work that you're doing with others in whatever geography that you're focused on, to see what others are doing and have a point of contact. Maybe that's to request an RFP so you don't have to write one. Maybe it's to ask about the vendor that somebody else has funded and whether that work is going well. Or to think about how did you get to fidelity of implementation when you did use an evidence base. So great comments. Thank you for those. And I'd certainly be happy to follow up if you want to talk in more detail.
Thank you.
Yeah. I see another question. Do we have time, Jessica, for this one, or?
We have time if you have time.
Yeah, I could take a few more minutes. Emily asks, related to Sean's question, our team has been seeing variation in policymakers' interest in addressing prevention now versus thinking of it as a complex issue that needs to be addressed, but not necessarily motivated to address immediately. I'm looking forward to looking at the resources, showing short and long-term ROI potential can be very helpful in these conversations. Yeah, so that's maybe an important comment, and I would agree with that, right? It relates to the evaluation piece. So many people want to think about return on investment. Economists think of return on investment as monetizing things and coming up with a financial calculation. And in business and industry, a chief financial officer of an organization takes everything into dollars and says, is the return on investment relative to another use of capital or funds? And that makes a lot of sense. I think you can think about that in terms of social interventions as well. But of course, we also have to understand that we're dealing with human lives. We're dealing with families. We're dealing with communities and community members. And we need to be careful when we think about monetization. Okay, how do we sort of monetize the value of a life saved or a life lost? There are health economists and others that do that, but we need to think about whether and how we do that and if it's an appropriate methodology. But I also think there's this important question of, if we do fund prevention versus treatment, or we make a decision, what is the time horizon for seeing a payoff, if you will, whether that's in monetary terms like dollars, or whether that's in other more objective terms like reduced morbidity or reduced mortality. So, Emily, I think if I understand your comment, that's probably what you're getting at. And I would agree with you that very important issues there as well about investments. And again, some communities may say we're going to take both a short and a long-term gain, but some of that may be driven by local community context in terms of how they perceive the most important pieces of the problem in their community today.
So we are at the end of our presentation. I'd like to thank everyone for coming today and for your participation. If you do have a topic that you'd like to hear, please send me an email and we can look for a speaker and get that out for you. I'd also like to invite you back, Dr. Scanlon, and maybe do a seminar on the evaluation process. We could probably come up with something for that. Our next TSS is Wednesday, November 20th, and will feature Dr. Larkin Strong from the Department of Health Disparities Research at the MD Anderson Cancer Center in Texas. And her topic is titled Family and Peer-Based Interventions to Promote Primary Cancer Prevention in Underserved Communities. The link is out in our CTSI newsletter, so feel free to register, and we hope to see you then. Thanks a lot, Dr. Scanlon.
Sure. Thank you. Enjoyed it. Take care.
Bye, everyone.